and welcome to our lecture today. We are going to spend some time talking about the musculoskeletal system. And so in particular, we're going to talk about bones, and we're going to talk about muscles, and we're going to talk about different types of injuries that can happen and different ways that we as nurses care for these individuals. I think the first thing, though, is that we need to kind of understand some of the anatomy that's involved in the musculoskeletal system. So let's just go ahead and get started. We're going to start by talking about bones. The bones in our body protect our internal organs. For example, if we think about our ribs and all the different organs that they protect our liver and our heart and our spleen. Our cranium protects our brain, right? The skull protects our brain, and our ribs and our sternum protect our heart and lungs. The bones provide shape to our frame to keep our body supported, and also for movement, right? So our bones and skeletal muscles and tendons and ligaments and joints all function together as a mechanical basis for movement. Our bones store minerals. Some examples are calcium, which is the most abundant mineral in the body, phosphorus, and magnesium. So we can think of the bones as like a mineral reservoir for the body. Bones are also the way we make blood. The marrow, located within the medullary cavity of our long bones, produce blood cells in a process called hematopoiesis. So this is an important word for you to know, that the production of blood cells that takes place in the bone marrow is called hematopoiesis. So let's take a look here. We can see the long bone, one of them, the femur. We can see here that red blood cells come from the marrow, along with white blood cells, including our lymphocytes, monocytes, eosinophils, basophils, and neutrophils, and also our platelets. And so it's a good time to have a reminder that our red blood cells help deliver oxygen to our tissues. Our white blood cells are the mediator of immunity, the immune response in our body, how we fight infection. And then our platelets, of course, are very important in that they help clot our blood. So if we get a cut or some kind of trauma, our platelets are very important in order to stop that bleeding. And these are from the medullary cavity at the end of our long bones. And so here are just some examples of some of the long bones in the body. We can see the humerus here in the arm, the radius in the ulna, the femur bone, the fibula, and the tibia, as well as the ribs. So just some examples of long bones in the body. Cartilage is something very important to keep our joints healthy. Every joint comes with a natural shock absorber in the form of cartilage. It's a firm, rubbery material that cushions the end of our bones and reduces friction in healthy joints, right? So it keeps our bones from rubbing against each other. Ligaments and tendons are also very important. Ligaments connect bones to other bones to form a joint, and tendons actually connect muscles to bones. So those are two important things to know. And also an example here. You hear people talk about an ACL tear. And so what is the ACL? It's the anterior cruciate ligament, and it actually connects our femur to our tibia in our knee joint, okay? So you can kind of take a look at this image here and see where that anterior cruciate ligament plays a role in connecting those two bones together in our knee. So if we have overstretching of a joint with some tearing of a ligament or a tendon, we have something called a sprain, all right? So that's how we define a sprain. Overstretching of a joint with tearing of a ligament or tendon. A strain is a little bit different. It's overstretching or tearing of a muscle, tendon, or ligament. And so we need to remember again that our tendons connect our muscles to our bones. And if we have an overstretching and an injury, we call these soft tissue injuries, either to a muscle or a tendon or a ligament, we are going to have some pain, right? Some pain, some swelling, some discomfort. And so the nice thing about really approaching a sprain or a strain is that we don't necessarily need to know exactly what happened. Was it a muscle? Was it a tendon? You know, without going to the doctor and probably getting an MRI or other studies, we're not going to know. The good part is that anytime we overstretch and we feel pain and swelling, we are going to treat it pretty much the same way, whether it's a sprain or a strain. So we want to avoid activities that cause pain to the injury. Now this is really important because what you need to try to think about is that you want to picture the muscle or you want to picture the ligament, and you want to imagine it as having a small kind of a tear in it or even a bruise on it. And so when you do something that causes that pain to get worse, what you're really doing is kind of pulling that tear kind of open. And we don't want to do that. That's why we want to immobilize these types of injuries and rest them so that healing can take place. So we want to avoid activities that cause pain to the injury, maybe by using an ACE wrap or by just simply resting. And so for the first 48 hours, we want to ice it for 20 minutes at a time, about every 3 or 4 hours. So we want to make sure we have ice packs ready to go in the freezer, and we want to keep that ice on there for about 20 minutes. You've heard maybe this acronym before, RICE. So in terms of a sprain or a strain, RICE stands for rest. So we want to rest the injured extremity. We want to use ice on the extremity. We want to use compression, which could be in the form of maybe an ACE wrap. And we want to elevate. So elevation will help decrease the swelling. So RICE is a very good acronym to remember. RICE is rest, ice, compression with an ACE wrap, and elevation. So if we, again, compress with ACE bandage after a sprain or a strain and elevate, we can reduce some of that swelling as well as immobilize. Okay, so let's talk a little bit about arthroscopy. Arthroscopy is used for diagnosing and repairing torn ligaments. Really what happens sometimes is that the surgeon will have to go in with a scope. And you'll hear people talk about they had a scope of their knee. So what does this actually mean? It means that they make very small incisions and they put a scope in with a camera so that they can see the tissue in the joint area. And then they have other incisions where they can go in and use tools to grind away the edges of the unhealed tear in order for healing to occur. So this is when there's been a tear and there wasn't proper healing that took place. And the person has had a lot of pain and swelling and it's not getting better. They can kind of go in and kind of grind away that scar tissue and then be very careful about the healing time so that then they have a new opportunity to heal that injury. So that's what an arthroscopy is. So oftentimes it can be used for diagnosis, right, to go in and actually see the level of damage that's been done, and then also they can fix the problem. I mentioned bursa here because you'll hear people talk about having bursitis, which is inflammation of the bursa. These are little fluid-filled sacs that help reduce friction between the bones, and they're located kind of all around the tendons and joints in the body. And these help provide a cushion. So here we see a knee joint, and we can see the red areas are where these bursa are located. All right, so let's take a little bit of time to talk about muscle. So muscle is another important organ that's involved in our musculoskeletal system. And the muscles are fibrous, dense tissues with the primary function of allowing the body to move by repeated contraction and relaxation. And so the muscles help us maintain our posture. Our muscles help stabilize our joints and are also essential in glucose regulation. So we store glucose in our muscles as well. And so there are some different types of muscle that we want to talk about. Striated muscle is also known as skeletal muscle, and because it's responsible for the mobility of the body and limbs. These are voluntary muscles. So striated muscle, which is skeletal muscle, is voluntary. That means that right now I am voluntarily moving my arm through my muscles in my arm. That's voluntary. I think about it and then I do it, okay? And so here are some examples of the skeletal muscles in our body. We can see that we have many skeletal muscles that help us with locomotion or movement. But we have some other types as well. We have some involuntary muscles. And so a cardiac muscle cell is an example of involuntary. In other words, I don't make my heart beat. I don't think to myself, oh, I better make sure that my heart is beating, right? That's involuntary. It happens automatically. And thank goodness for that, right? Like we said, skeletal muscle cells are voluntary, meaning that I will my muscles to move. And then there are some other involuntary muscles called smooth muscles. And so the best example of a smooth muscle would be, for example, the peristalsis that takes place in our bowels. So actually in our esophagus, when I chew up a bolus of food and I swallow it, I don't make the muscles in my esophagus push that food down. My involuntary muscles do that. So peristalsis happens all throughout our GI tract by the use of these smooth muscles that we do not voluntarily control, okay? So that's the difference between the three different types of muscle. So our bones, our skeletal muscles, our tendons, our ligaments, and our joints all function together as the mechanical basis for movement. So let's take a little bit of time and learn about joints. Joints are the point where two or more bones meet in the body. And we have three main types that we're going to talk about in this lecture. We have fibrous joints that are immovable. And so example of these would be the ones that are in our skull. So we have these fibrous joints such as the coronal sutures that hold our cranial bones of the skull together, all right? But these are not movable. We have cartilaginous joints that are partially movable. And so the connection between the bones is made up of cartilage. And so a good example of this one are our intervertebral discs, okay? So we've got these vertebral bodies, and then we have these cartilage type discs that kind of connect those bones together, and these are partially movable. And then we have synovial joints. And these normally provide free movement between the bones that they join, okay? Synovial joints, they have a capsule or an outer fibrous layer, and then they have an inner membrane called the synovial membrane. And we're going to talk a little bit more about these because these are very important for us as humans to be able to have free movement in our bodies. When we have diseases associated with our joints, it can be very debilitating. And so here we see a knee joint. We can see here the femur bone. We can see the synovial fluid that's in blue. We can see the patella, which is kind of our kneecap, and the synovial membrane. We can see there some of the cushion, right? We see some of that cartilage, the articular cartilage, and then we see the other bone that connects at the joint, which is the tibia. And so what we want to think about is this joint is covered with this fibrous capsule, and it surrounds the joint. And what this fibrous capsule has is synovial fluid. And synovial fluid fills the joint cavity, and it provides lubrication and shock absorption. And so when we think about it, you know, we jump, we run, we do aerobic activities, we do things that can be, you know, put a lot of kind of impact on our joints. And so it's this cartilage along with the synovial fluid that kind of helps with shock absorption. And so we're going to discuss actually 3 types of synovial joints. We're going to talk about hinge joints, we're going to look at pivot joints, and we're going to look at ball and socket joints. The first one we're going to look at is the hinge joint of the knee. So the knee is a hinge joint, and it kind of has this action of flexion and extension, right? So we have our femur bone, and we have our tibia bone, and then what our knee is able to do is to flex and extend. Flexion is when we bring something towards the body, and extension is when we move the limb away from the body. So that is the knee joint. Our elbows and knees are both examples of hinge joints that do permit flexion and extension. We also have a pivot joint. C1 and C2 are example of pivot joints. And what this allows us to do, there's rounded process of bone, and it rotates within a ring composed of a bony fossa. So C1 and C2 allow us to rotate around a central axis, just like I'm showing you right here. So this is my neck. I'm being able to move back and forth because of my ability to do circumduction from my C1 and my C2. So this is to rotate around a central axis. And we can see here in the image of the bone that there is kind of a bone that sits on top that's kind of a ring. And with our muscles and our ligaments, it allows us to move from side to side. Okay? We also have ball and socket joints. And one of my favorite examples is the hip joint we can see here. And it's important for us to understand some of the anatomy that goes into this ball and socket joint because what we can see here is our pelvis. We can see that the pelvis has an acetabulum, which is kind of like a place for the femoral head to fit into, okay? So a ball and socket joint fits in this way. So we've got the acetabulum here, we've got the femoral head here, and it connects in this way. And then, of course, remember, we've got that cushion and that synovial fluid allowing that bone to move freely inside of that joint. And so we've got cartilage in the femoral head, and then we have our femur bone. And it's also really important to note here that we have a femoral neck. And the reason why is because oftentimes when there is a hip fracture, the fracture will happen in the femoral neck. And we're going to talk more about fractures of the hip in another lecture. Right now, what I want you to do is get an understanding of some of this anatomy, okay? And the ball and socket joints really permit a lot of different types of movement: flexion and extension, adduction and abduction, and medial and lateral rotation. And so what that means is, we'll go over them again. So flexion is when I bring the limb to my body. Extension is going away. Adduction is when we're bringing something towards the body, okay? So if this was my leg, right, I can move my leg this way. Abduction is when I'm moving away from the body, okay? So abduction. And then medial and lateral rotation has to do with our ability to rotate, okay? And there are really good explanations of all these different types of movement in your textbook as well, so I encourage you to take a look at those. So if there is a dislocation, what that means is there's a separation of two bones where they meet at a joint. And so here what we're looking at is the hip bone again, the hip joint. And on the one side we see a normal hip joint, and on the other side we see where the hip joint has been dislocated. And what that means is that due to some kind of injury, the actual head of the femur is no longer placed correctly in that acetabulum. For some reason, due to injury or trauma, that has been separated out of that space, okay? And this can be very painful. So this is when the head of the femur is dislocated from the acetabulum of the pelvis. And what I have on this next slide is an example of a hip that has been dislocated after a person has had a hip replacement surgery. And so hips can become dislocated either if you've never had surgery or after surgery. It is a risk. So if you have had your hip replaced and somehow you move it in a wrong way, or maybe you fall down, it can be dislocated. And you can see here in the x-ray that we can see the prosthetic head of the femur. Prosthetic means that they have used some kind of artificial new femur that's made out of artificial material to take the place of the femur. And the acetabulum, you can see there, also has screws actually coming out of it. And so the new acetabulum is put into place, which is also a prosthetic. And those screws that you see are going up into the pelvis, keeping that acetabulum into place. But what you see has happened here is that the femur bone has come out of the acetabulum and been dislocated. This requires a trip to the emergency room and then treatment by the doctor or the surgeon. Subluxation is a word that you will hear, and what this means is a partial dislocation. So in other words, it's not fully dislocated like we see in this image right here. Maybe subluxation is a little more like the image that we see here, where there's a partial dislocation. Okay, so what do we do about it? You can get something called a closed reduction. A closed reduction means that you're reducing the dislocated joint under sedation, maybe. You're giving the person some medication, maybe to kind of help them like forget, or some pretty heavy pain medication so that they don't feel it, but that the physician will actually reduce that dislocated bone. Like shoulder reduction often occurs in the emergency department where someone dislocates their shoulder. The physician will come in, no surgery needs to be done, and that shoulder gets kind of put back into place by manipulating it in a certain way. And this can be very painful. However, it's kind of nice to be able to get the shoulder put back into place without having to go under a surgical procedure. Open reduction, on the other hand, is different. Open reduction is when we reduce the dislocation by a surgical procedure. So for example, if somebody had a dislocation of the hip, like I showed you in that previous x-ray, it's very likely that that would have to be reduced, that those bones would have to be realigned back in that joint through a surgical procedure. So let's talk a little bit about some diagnostic testing. We talked a little bit about arthroscopy a little bit ago, and we said that this was used for diagnosing and repairing torn ligaments using a camera and a little scope where we go in and we can look and we can use instruments through very small incisions. This is a more favorable way of doing surgery because you don't have a large open incision. So the healing time is a bit quicker and we have less risk for infection by doing it this way. We can do arthroscopies on shoulders, elbows, wrists, sometimes hips, and ankles. And so it's not just the knee that we can do this type of procedure on, but other joints as well. Fluoroscopy is an x-ray machine that's on a C-arm, and it's kind of like an x-ray movie. And what happens is it allows the physician to diagnose what's happening by displaying the movement of a body part in detail. And it can also be used during a surgical procedure to realign the bones. And so this is kind of what it looks like. You can see here that the fluoroscope is on. The surgeon is able to look on a screen at whatever the bones are, and they can kind of see how those bones are moving and articulating underneath the fluoroscope. MRI is another way for us to diagnose problems with soft tissue injuries. And remember when we said soft tissues were muscles and bones, well, ligaments and tendons and bones we can see on x-ray as well. So radio wave and magnetic fields are used to view these soft tissues. Sometimes we use contrast material during MRIs for better viewing. So examples would be a ligament or cartilage tear that we might look at on MRI, osteomyelitis, which is an infection of a bone, which we're going to talk about a little bit more, and disc disease. So this would be in the back, on the spine, looking at diseases of the disc. So here's an MRI of the lumbar spine, and you can see on this, we can see the vertebral body. We can also see a normal disc, but if we look down lower, we can see the herniated disc. See how that herniated disc is herniating out kind of into the spinal column. So that is an MRI of the lumbar spine. It's important to know what some contraindications for MRI. If we have any metal in our body, pacemakers, any kind of aneurysm clips, hearing aids, if you've been in war and you have shrapnel in your body, or metal on clothing. So we want to make sure that there is no metal going into the MRI machine. Here is a picture of a closed MRI. And I don't know if any of you have ever had an MRI. I have lectured about this for many years, but it wasn't until I actually had a closed MRI that I realized why it is that people sometimes get offered a medication like Xanax before going in. Closed MRIs can be very difficult for people who are claustrophobic. And so we also have an option to get an open MRI. So this is what an open MRI looks like. And this is what a closed MRI looks like. So I want you to imagine this individual laying here. Once the test begins, that table slides into that very small tube. And when you open up your eyes, you really do feel a little bit panicky because you are really in a very tightly enclosed space. And I did not realize that it was going to bother me as much as it did. So I had to take some deep breaths and kind of talk myself down from it. The reason I'm telling you this story is because it's really important to educate our patients about really what's going to be happening when they go into an MRI. And if they have any problems with being claustrophobic, they probably either need to have an open MRI or they need to be able to take some kind of a benzodiazepine before we put them in the MRI. So just good nursing consideration to remember there. Standard x-rays can show us things like bone density, fractures, dislocations, and pretty much just like the integrity of the joint. But standard x-rays don't really show us a lot of soft tissue types of injuries. All right, so let's take a little bit of time and talk about osteomyelitis. We said that it was acute or chronic infection of a bone. It's when a microorganism enters the blood and gets into the bone and actually infects the bone. These infections are difficult to treat because blood supply to the bone is scant, meaning we don't have a lot of vasculature kind of contributing to our bones. And osteomyelitis is usually requires about 6 to 8 weeks of IV antibiotics. So it's usually outpatient where you might have to get a midline put in or even a PICC line and then go in for periodic antibiotic therapies all throughout a 6-week period to try and deal with this osteomyelitis, this infection of the bone. It can actually cause a death of the bone tissue. Death of any type of tissue in the body is called necrosis, and necrosis is permanent. That means that it is not reversible. And so here we can see a bone infection in the metatarsal bone of the foot. And close up, we can see this phalangeal joint infected, and there's kind of swelling, there's purulent type of drainage in there, can be very painful, and can also result in death of the bone if it's not properly treated. So who's at risk for these types of infections? Diabetics are. Diabetic foot ulcer can become infected and cause infection in the bone. Patients with hemodialysis, so patients who have renal failure, who get hemodialysis 3 days a week, can get a type of microbe that gets introduced through the bloodstream. And we would call this a let's see, how do we pronounce this word? Hematogenous. So a hematogenous spread through the bloodstream from dialysis. Patients that have immune compromised situations, so a patient maybe with HIV, patients who take steroids, patients who are being treated for cancer, may have compromised immune systems, which increases their risk for infection. People who are IV drug users are going to be at a high risk for osteomyelitis because injecting dirty needles into the body can introduce microbes into the body as well that can then go and infect bones. And then always children under 5 and our elderly kapuna are always at a higher risk for infections as well. Those who have had a splenectomy, that have had their spleen removed, are at a higher risk for osteomyelitis because the spleen actually helps filter bacteria from our blood. So if we don't have a spleen, then we don't have that organ doing its job to filter out that bacteria. Having a splenectomy can put us at risk for other infections as well. So what are we going to do about it? What can we do? We said that we can do IV antibiotics. If that isn't working, we can drain the open wound or the abscess with needle aspiration, where we put a needle into the affected area and we draw out some fluid. We can take this fluid and culture it to identify whatever the microbe is that's causing the infection. Sometimes it's Staphylococcus aureus, fungus, or other types of bacteria, which will allow us to choose the correct antibiotic to fight whatever the infectious agent is. We said IV antibiotics, but surgery can also be a therapy for this. We would need to take a chronic bone infection to be treated through opening it with a surgical procedure during which the infected or necrotic bone is scraped out and kind of cleaned out. So that is our lecture, kind of covering the musculoskeletal system. Today we talked about bones, we talked about muscles, we talked about ligaments, tendons, joints. We talked about strains and sprains and different types of bone infections. It's important to understand the foundations of the anatomy. And now we're going to spend some time in the next lectures talking about some other problems that can occur in the musculoskeletal system. So I thank you for your attention, and I'll talk to you next time.